Welcome to another session of Next Gen Forum organized by the Young Internist Hub of Sri Lanka College of Internal Medicine. The Next Gen Forum is a unique platform in which the next generation internists share knowledge and perspectives through case-based discussions on clinically relevant topics. In keeping with this vision to bring novel insights into important and common areas in internal medicine, today's forum will focus on an important and timely theme on tropical medicine, an area of immense interest. So we hope to generate valuable insights that will enhance our collective understanding of the audience and guide us for a better patient care. Today, we are looking forward to an engaging and thought-provoking session ahead. To commence today's webinar, let me invite the President of Sri Lanka College of Internal Medicine, Dr. Krishantha Jayasekara, to welcome the gathering. Over to you, sir.
Thank you very much, Sahan. I think this Next Gen Forum actually was created as an extension of Senior Registrar Forum, which was in existence for the last 4 or 5 years. It was actually an active platform where we actually groomed our young internists, and now most of them are now consultants. So we thought we will advance further. We will get them their expertise, to share their expertise with the peers as well as senior colleagues. So this for today is the 5th such Next Gen Forum webinar that we are conducting. And on behalf of the college, let me invite all the virtual participants as well as a speaker today, none other than Professor Chamara Dalugama. And of course, this forum was headed by another young internist, Dr. Sahan Mendis. So without further ado, let me invite Sahan to introduce Professor Chamara Dalugama and proceed with the webinar. Over to you, Sahan.
Thank you, sir. So first of all, let me inform you some housekeeping messages, which will be very important for the audience. Participants are muted throughout the lecture, so they can forward their questions by typing in the Q&A box. Questions of the audience will be taken at the end of the lecture. The participants, very importantly, participants will be offered CPD points accredited by the Ministry of Health, Sri Lanka. So we will share a QR code which attach the link for a Google form, and we will also display a link for the Google form in the chat box during the Q&A session at the end of the lecture. So the participants need to scan the QR code or click the link to access the Google form and fill the Google form to obtain the e-certificate with CPD points. Only the participants who fill the Google form will receive the CPD points and the certificate. And please kindly note, it will take around 2 weeks for you to receive the CPD certificate. Right. So let me now introduce our speaker of the day, Professor Chamara Dalugama, MBBS Peradeniya, MD Colombo, MRCP UK, MRCP Acute Medicine, MRCP Diabetes and Endocrinology, MRCP Geriatrics, FRCP Edinburgh, FRCP London, and FRCP Glasgow. So if I introduce Professor Chamara Dalugama, I think all of you know it will be a very lengthy introduction. So, but I should tell that he is a graduate from the University of Peradeniya, who has graduated with first-class honors in year 2013, securing distinctions and gold medals and prizes across almost all subjects and ranking the first in the all-island merit list. He went on to obtain his MD in 2019 alongside the MRCP qualifications from the UK in acute medicine, diabetes and endocrinology and geriatrics. And he is a fellow of the Royal College of Physicians of Edinburgh, London and Glasgow. And he's an accomplished clinician, academic, and a researcher who has published widely. And he was also a former secretary of the Sri Lanka College of Internal Medicine. He was the chairperson of the Board of Study in Clinical Sciences at the PGIM and coordinator of the Center for Research in Tropical Medicine at the University of Peradeniya. His outstanding contributions to teaching have been recognized with multiple awards, and he has also received numerous prizes for his academic excellence. So we are pleased and honored to have Professor Chamara Dalugama with us today to share his expertise in tropical medicine. So he will be talking to us on fevers not to be missed in the tropics. So let me invite Professor Chamara Dalugama to address you all. Over to you, Professor Dalugama.
Thank you very much, Dr. Sahan. And yes, it is indeed a great pleasure to be invited for the Exchange Forum. And first of all, I would like to thank Sahan for inviting me as well, because when he asked me to talk in this forum, I was wondering like what to talk. And then suddenly the topic that I'm going to talk to you today, fevers, yeah, I think you can see my slides, right? Yeah.
Yes.
Yes, okay, great. So fevers not to be missed in the tropics. So that is the topic that I chose. And I think you must be wondering like what I'm going to talk to you today. So I'm sure you will all have a non-exhausting list of causes of fevers that should not be missed in the tropics. But today my focus will be on two important tropical infections which are often overlooked by the treating physicians, and sometimes there are significant delays to the diagnosis, as well as this delay can lead to disastrous patient outcomes, as well as some can have significant public health impact as well. So you must be thinking, what are those two fevers that I'm going to talk to you? Well, the first part of my talk, I will be talking about malaria from a physician's perspective. I will tell why I have added that part. And the second part, I will be talking about melioidosis. Both are very important tropical infections that we should know. So coming to the first part, the malaria from a physician's perspective, right? So the question that I'm going to ask you at the end, or I want you to answer is, are we at another malaria epidemic? So first of all, I must tell that I'm not a subject expert in malaria. So I'm not going to discuss a lot of things about, the diagnostics or advanced or complex management issues here. But I'm going to talk about a very simple fact with regard to malaria, which I believe is the bottleneck. Because to your left hand side, you can see the anti-malaria campaign of Sri Lanka, where the office is located. And I mean, it's a very robust system is there in our country with regard to the management of malaria, right? So all what we are missing is that we hardly suspect malaria in patients. So that is the bottleneck. Once we suspect malaria in a patient and once we confirm the diagnosis, from that point onwards, everything is very well streamlined, very clear, and we get the help from the anti-malaria campaign. And so that part I'm not going to talk in detail because that is already in place. But the problem comes, we are not suspecting malaria. So first of all, I would like to take you through few authentic cases where I was, I would say, personally involved. And then you will see why was the delay and how could that have been prevented. Right, so let's move to the case number one. So case number one is a 71-year-old male who is a farmer by profession. He's from Pilimatalawa and he was previously well and he had fever for 6 days. Arthralgia, myalgia, shortness of breath with an unproductive cough. And he was seen by the family physician and he was started on coamoxiclav and azithromycin with some cetirizine, panadine and dexamethasone. But his symptoms persisted with high spike in fevers, so he was admitted to the hospital. So on admission to the hospital, he was ill, mildly dehydrated, not pale or icteric, no palpable lymph nodes or skin rashes. And he was hemodynamically stable and normal cardiovascular and respiratory system examination. And these are his initial investigations, right? He had a almost normal white count with neutrophils 80%, hemoglobin of 10.9, marginally low platelets, I would say 167, normal clotting, And there was a bit of a transaminitis. SDLTs were like 129 and 79. Slightly raised bilirubin of 31. A creatinine of 126 micromoles per liter. A CRP of 25 and a normal chest X-ray. So with the history, the examination findings, and based on the initial blood workup, the working diagnosis of the medical team was a viral infection with a secondary bacterial chest infection. So he was asked to, azithromycin was completed and he was started on intravenous ceftriaxone 12 hourly. But the problem was he was having high fevers, continuous high fevers, and patient was feeling very poorly. So then the question came, are we missing anything? Well, so we revisited the patient story. There was one crucial question that had been missed from the patient's initial clerking. Whether there is any recent travel history out of the country. Probably the house officer who has clerked must have thought, now this is a farmer, 71-year-old farmer from Pilimatala, why should I bother to ask whether he has been out of the country, right? So this question was not asked. And then the answer was a proud yes, because it's first time in his life he has been on a pilgrimage to India with a team of 18 members 3 weeks back. And from Katunayaka to Chennai, then he has traveled by train to Bodh Gaya, and he has traveled to many places. The rooms did not have mosquito nets or repellents. The trains they traveled were open, and he was not at all aware of something called chemoprophylaxis against malaria. So then it was suspected, and the malaria antigen was positive on blood, and the thick and thin smears showed trophocytes and gametocytes of Plasmodium vivax with a parasite density of more than 6,000 per milliliter. So on the 5th day of hospital admission, and unfortunately on the 11th day of fever, a diagnosis of Plasmodium vivax malaria was made. Right? So let's move to the second case straight away. So this is a case of a 19-year-old university student. This happened like maybe 6-7 years back. 19-year-old university student from England, and he's on holiday in Sri Lanka. And he presented to a private hospital with a 4-day history of high-grade fever and chills. He was having severe myalgia and headache. And this guy was in Sri Lanka for 2 weeks. And he was involved in a lot of recreational activities. He was climbing mountains, freshwater bathing, and outdoor camping. And on examination, this young boy was ill-looking, febrile, icteric, and there was tenderness over the right hypochondrium. And his respiratory and cardiovascular system examinations were normal. So the initial blood workup, he had a white count of 10, hemoglobin of 10.2, platelets of 78,000. His clotting was normal. There was a transaminitis, AST and ALT were elevated, and ALT was 400s, high bilirubin, and a mild AKI. Creatinine was 146 micromoles per liter with normal electrolytes. So with the history, the examination, and the initial investigations, a working diagnosis of leptospirosis was made. It is based on his exposures, the compatible incubation period, the examination findings, and the investigations. And he was started on intravenous ceftriaxone. And on day 3 in the private hospital, he was still spiking high fevers. He became confused, and hemoglobin dropped from 10.2 to 7.3. And platelets were dropping from 78,000 to 35, and high bilirubin level and high LDH. Again, the question, are we missing something? Well, patient was transferred to TH Peradeniya on day 4 at 7 p.m. and he stayed revisited. And it's true that he's from England, but before coming to Sri Lanka, he has visited and stayed 2 weeks in Ghana. And he recalls having multiple mosquito bites, outdoor nights, which was retrospectively asked because he was confused at the time of admission to Peradeniya. And then he has taken malaria prophylaxis, but the compliance was questionable. So on day 4, his malaria antigen was positive. Thick and thin film showed Plasmodium falciparum malaria with a high parasitemia. And it was complicated with an acute kidney injury, lactic acidosis, anemia, and hypoglycemia. So a diagnosis of severe falciparum malaria was made. Right, so what was the problem here? Now in both cases, as a country, we have a very low disease burden, right? So as you know, in 2012, we had the last case of malaria, the indigenous case of malaria. And Sri Lanka was declared malaria-free in 2016. So we have a very low disease burden. I'm very sure that most of the young colleagues here have not seen a malaria patient, right? So because of the low disease burden, we hardly see patients, so there is a very low clinical suspicion. And the low clinical suspicion leads to significant delays in the diagnosis. So an uncomplicated malaria can become severe life-threatening malaria with that delay, which has happened to the second patient that we just discussed. Right, so this is from the anti-malaria campaign. So they are now working for prevention of re-establishment phase, right? So this is back from late 2024, no indigenous cases. There were 29 imported cases and 1 death, and that is also from an imported case. Right. So the question I asked is, are we at risk of another malaria epidemic? Well, talking from the local context, the answer is yes, right? Although we have eradicated malaria, the indigenous cases of malaria, the vector is still there. It is widely distributed in Sri Lanka. And we do get a lot of imported cases, right? So now we are talking Sri Lanka being listed as one of the top destinations for foreign travel or for the tourists, right? So we get a lot of tourists from endemic countries. We get migrant workers, peacekeeping forces. So we are at high risk of getting imported cases. And then the diagnostic delay that happened in both patients. The clinicians have a low suspicion. We hardly think of malaria when we see a fever patient, right? Because the local transmission has ceased. And then the population immunity. Now the general population is not immune. So there is a higher risk of outbreaks if transmission resumes. And there are a lot of changes in the climate as well. So the rainfall pattern has changed. Now the dry seasons are becoming drier and drier. The wet seasons are becoming wetter and wetter. So there are a lot of changes in the rainfall pattern. And there are a lot of irrigation projects going on which favor the mosquito breeding. And finally, there are a lot of health system challenges as well. Still, we have a very robust system. The anti-malaria campaign is highly proactive, but the resources are getting diverted to dengue, getting diverted to these days to chikungunya and other diseases, so that there can be certain issues with regard to malaria surveillance. So due to all these factors, as a country, we are at increased risk of re-emergence. So that as clinicians, as physicians, as first contact doctors, we have to be very vigilant. And one important question that you should not miss is to ask about travel history. It's a very simple thing that you always tick that box when you are clerking a patient or when you are seeing a patient with a fever. Right. So when to suspect malaria, right? So I would say any febrile individual, think about malaria, right? Any patient who had unexplained fever and a travel history to a malaria endemic country. And this recent travel is within 1 year. It is not within last 2 months or 3 months. Even up to 1 year, there can be malaria parasites. The hypnocytes can be dormant in the body and they can get reactivated. So you have to think about this, right? Any febrile individual, ask about travel history, and if there is a significant travel history, you need to suspect malaria. So the high risk groups include the businessmen, the pilgrims, the seamen, resettled communities, refugees, asylum seekers. And sometimes, and the other thing is any individual presenting with clinical features of severe malaria, which I have a slide later on, so I will discuss what are the features of severe malaria. And fever is not a universal finding in malaria. Malaria is not equal to fever. So any patient with anemia of unknown cause, ask about travel history. Just in your differentials, lower down, keep malaria also. And any patient with hepatomegaly or splenomegaly, unexplained hepatosplenomegaly, you need to think about malaria. And also, interestingly, any patient who develops fever within 3 months of receiving a blood or blood product transfusion, you need to suspect malaria, right? So this is a big list. So any patient with fever and any patient with one of these features, you need to think of malaria. And as I mentioned, fever is not a universal find in malaria. Sometimes there can be patients with malaria without fever. And the other interesting thing is thrombocytopenia is fairly a common lab finding. So both of our patients I discussed earlier had thrombocytopenia. And that can be commonly mistaken. Fever with thrombocytopenia, yes, we do think about dengue, we think about leptospirosis, rickettsial infections, and nowadays we think about high spike in fevers with low platelets and aches and pains, we think about chikungunya. So malaria should be there in your list of differential diagnosis. So features of severe malaria, this is a big list, but I'm not going to read this out for you. But certain things like reduced level of consciousness. And then this is interestingly, but the word prostration. Basically what it means is the patient is too weak to get up or sit up without assistance. And having convulsions, and then pulmonary edema, circulatory collapse, acute kidney injury, abnormal bleeding. So all these are features of severe malaria. So you might get a very sick patient where you are unable to take the history, but he has these features of severe malaria you need to think about. You need to sort of hunt for that as well. So diagnosis, as I mentioned, I'm not going to talk in detail, but the rapid diagnostic tests are available and the microscopic examination of blood smears. And then the treatment, again, you don't have to by heart any of these things, because once you suspect malaria, once you make a diagnosis of malaria, there is a team that is willing to help us with the management, rest of the management. Right. So severe malaria is a medical emergency. So ICU HDU care is needed. The patient needs close monitoring. And in severe falciparum malaria, we use IV quinine. And you need to be vigilant about common side effects like hypoglycemia and certain QT changes and hypotension. Right. So to sum up the first part of my talk, in patients with malaria, it is mandatory to treat all patients with malaria as inward patients for at least 3 days. And as Asians, we do have a lot of patients with G6PD deficiency. So particularly in Plasmodium vivax, where we use the anti-relapse therapy to kill the hypnocytes, we use primaquine. So you need to test the patient for G6PD deficiency. And we have the mosquito just, outside. Therefore, patient should be managed under a mosquito net until the parasitemia clears. So few practice points that you should know. And then when you suspect or when you diagnose a patient with malaria, it has to be immediately telephoned, immediately be notified via telephone to the regional malaria officer and AMC headquarters, and also notified by the medical officer of health. So this notification, this was given even for the lab technician. So if the lab technician finds a positive malaria antigen or the blood film shows Plasmodium, yes, he can inform the ward, and at that point he can inform the regional malaria officer. Right. So coming to the last case here. So this, I think you will all agree, that's a common thing that we all encounter. Now let's listen to the case. So there is an elderly couple in their 70s coming to their GP and state that they're planning to visit India on pilgrimage in 2 weeks' time. And they have come to ask for a prescription of their routine medication so that they can carry them in their luggage. And also they tell, give something for my cough and I have some joint pain, so give some analgesics, give something if I develop a diarrhea, right? And they're planning to stay 18 days in India. So in addition to, giving what the patient requests, what advice would you give for them, right? This is again a place where you can play a pivotal role in prevention of re-emergence of malaria in Sri Lanka, right? So chemoprophylaxis for malaria. So the most appropriate chemoprophylaxis for the destinations should be prescribed in the correct dosage for the recommended period. So what to give? It depends on many factors. It depends on the country that you are going to travel. Whether you are going to travel to India or whether you are going to travel to Madagascar, Sub-Saharan Africa, the type of chemoprophylaxis is different. And then what type of a traveler you are? Are you a last minute, like you come, I'm going tomorrow morning, the flight is at 9 o'clock, so you come in the evening and asking for a prescription. Or whether it's a planned travel, or whether you are going to stay for a longer period in that particular country. And also the patient's past medical history, where the patient has allergies or whether the patient has D6PD deficiency, right? Right, so what to give? Again, I'm not going to discuss in detail because it's a bit of a complicated table, complicated chart. But in general, if you are going to India, where the vivax malaria is common, generally they prescribe chloroquine, and particularly if you are going to the African countries where the falciparum is there, so the first line would be to give mefloquine. Now, how to arrange this anti-malaria prophylaxis? I think it's going to be one of your questions, right? It can be easily arranged through a OPD referral to the regional malaria officer. So if you are, so I was just checking what is the status in Peradeniya. So it's a very simple OPD letter to the public health field officer in Peradeniya, and he has a stock of chloroquine in appropriate doses and all that. So he will get all your information, will be sent to the anti-malaria office and the headquarters, but that can be issued then and there. But if you are going to an African country, he will liaise with the anti-malaria campaign and he will get down the mefloquine from anti-malaria headquarters. So it's a very, very simple process, but you have to be aware of that. So you need to do the appropriate referrals, and to arrange chemoprophylaxis, whenever you get this opportunity, where patients will come and ask for certain prescriptions, or when a patient tells that he's going to go to India or Africa or whatever, right? So this is again an important point that I want to highlight. So coming to the last slide in the first segment of my talk, so we need to keep Sri Lanka malaria free. So you have to be aware of the risk of malaria in the country that you are going to visit. Try to avoid mosquito bites and always consider chemoprophylaxis when indicated. And diagnosis in fewer patients, we should avoid diagnostic delays, and we have to also early and effective treatment. And finally, if the diagnosis and treatment delayed, it can be proven fatal. Right. So I think, right, so that is my first part of the talk. Again, the point that I want to emphasize is that the bottleneck in or the most important part in preventing re-emergence of malaria in Sri Lanka is, as physicians, we have to suspect malaria, because still we get only the imported cases. So you should not allow a significant diagnostic delay for weeks when the patient is too ill to make a diagnosis of malaria. Right. So let me come to the second part of my talk. Right. I think I will entertain the questions at the end of the both segments. So yeah. So the second part, I'm going to start with a recent, I would say like 4 or 5 years back, a recent news about a mysterious fatal infection, right? So this was actually the talk of the town during this period. This news was in most of the headlines in local and international newspapers, right? So I'm going to talk to you about 4 patients, right? So I will quickly tell the patient number 1 is a 55-year-old female from the US, the state Kansas, and she dies because with a septic shock with pneumonia, and the post-mortem reveals multiple lung abscesses. And the second patient is a young boy from Texas, again sepsis with pneumonia, and luckily he survives. Patient number 3 is a 53-year-old male from Minnesota, and she again develops septic shock with pneumonia and septic arthritis, and he survives. And the fourth patient is a young boy from Georgia, and sepsis and pneumonia. He dies on 4th day of admission, and post-mortem reveals multiple lung and brain abscesses. Right, so there are 4 patients over a period of 3 to 4 months in 4 different states in the United States, far apart. Right, so this can be often overlooked. Right, I mean, so all are very explainable deaths, but they had a very rigorous, vigilant surveillance system that this triggered a bell, right? All patients' cultures are isolated in a Pseudomonas species. And all these cultures were later confirmed as a Burkholderia pseudomallei, right? And when I was going through this story, I was thinking sometimes in the same medical ward, in 4 different cubicles, we have 4 patients with the similar illness, but we hardly make a link between these 4 patients. But this happened 1,000 miles across 4 states, 4 entirely different patients, pediatric ones, adult ones, some surviving, some dying, but with a pneumonia, which is a very common medical problem, but they were vigilant to draw the link. So all were confirmed as Burkholderia pseudomallei, and they were thinking, why? How did they get this infection, right? So none had traveled to tropical countries, right? And then they got the help of a big team, and they were looking for items that were exposed. to them, or the patients that have been exposed to various items, right? And then in all 4 houses of these 4 patients, they found this bottle. This is an aromatherapy spray bottle, right? And they were able to isolate this Burkholderia pseudomellii, the same genetic footprint in the bacteria in all 4 patients, and all 4 patients were exposed to the same brand aromatherapy spray bottle. And they serotyped it, and the strain was clustered with samples of Burkholderia pseudomellii from South Asia. And actually this was imported from South Asia, from South India, to the Walmart shops in US and UK. So these were the exact paper cuttings that time: mysterious fatal infections tied to room sprays sold at Walmart, and India made spray linked to rare illness in US. Likewise, it was all over the newspapers and people were talking about this. So then the all Walmart users were asked to stop using this product immediately, because there were many patients who have purchased this aromatherapy bottle. So they asked to not to open the bottle, not to throw it away, and put it in double bags and a cardboard box and hand it over back to the Walmart store. And then those who have exposed to this product, getting fever within 21 days, they were asked to seek medical care immediately. And even those who have not having symptoms but exposed within last 7 days, this was the first time they described post-exposure prophylaxis for melioidosis, right? So they were treated with trimethoprim sulfamethoxazole or coamoxiclam. Right, so that's a story where the 4 patients finally linked to a aromatherapy bottle imported from India, which was contaminated with this bacteria. So you can understand this is a potential bioweapon that can cause very serious outcomes. And this is one of the common infections that we do see in our medical wards as well. So that is why I wanted to highlight some important points with regard to melioidosis. So it's a gram-negative bacterium, and it is commonly found in the soil and the surface groundwater of the tropical and subtropical regions. And particularly during rainy season, now it stays in the rhizosphere lower down, and then particularly in the rainy season, this bacterium moves to the surface for the reproduction. And that is exactly the very time where our farmers will go and dig and turn the soil upside down. So then there are in a lot of ways, by inoculation, ingestion, inhalation, this bacteria is getting into the system, right? And this is a very robust, very, very strong bacterium. So it can survive in extreme conditions. So even in distilled water without any nutrients, it can survive for more than 16 years. It is seen in nutrient depleted soil, desert environments, contaminated water supplies. And there was a recent few cases reported in South India. They found a lot of Burkholderia pseudomellii in wound irrigation fluid, antiseptics and hand wash detergents. So they survive extreme conditions. So why it is important to us, you can understand by looking at this map, right? So the size of this blue dot equals the number of reported cases, and we can hardly see our tiny island because the dot is too big, right? So it is a common infection. Now there's a lot of awareness of melioidosis, so more and more cases are getting reported. So this is something important that we should not miss. Right. So again, I know this is going to be a bit of a boring part where if I'm to talk about the history of melioidosis, but some interesting points where the first human case reported in South Asia is from Sri Lanka in 1927. And there were so many cases reported afterwards, right? But it was it was neglected, that as neglected tropical diseases. But then in 1967 to 73, there are around 350 cases of melioidosis reported among American soldiers, right, who worked in Vietnam. And then that opened the eye of the world, right? So the American soldiers are getting melioidosis. So now everybody is talking about melioidosis. And a few years after that, the ceftazidime was found to be effective to treat melioidosis, and which of course halved the mortality from 74% to 37%. So then over time, this was classified and sequencing was done. And then the eradication therapy was introduced in 2014. And in 2016, with all the information we have, the modeling studies predicted that melioidosis is no simple. It can account for almost 90,000 fatalities yearly. So a serious infection, and it was sort of classified as a tier 1 agent, a select agent by US CDC. Right, so this is interesting because this is the first ever case report about melioidosis in a human, and this was published in one of the Sri Lankan journals, the Ceylon Journal of Science, 1927. And if I am to read the last couple of sentences, in this paper, the authors record a case of human melioidosis occurring in a European living in Ceylon. A specimen of pus was aspirated from the lung shortly before death, and Burkholderia vimori, which was the name that time, was isolated. And the organism was fully identified and gave rise to typical lesions in the guinea pigs. And that is how they proved the Cox postulates, and they confirmed the case of melioidosis. That was the first ever case reported. So how do we get melioidosis? It can penetrate through the skin, and it can be get into the system through ingestion, inhalation, and there are few cases where vertical transmission is reported. And the other important thing is, for a country like us, we need to suspect melioidosis only in individuals with Burkholderia pseudomelia infection who develop clinical symptoms. This can be the acute or chronic, because we do test the antibody levels. And most of us, if we test our antibody levels, we might get a low titer, because it is ubiquitous. We get exposed to Burkholderia, so we can have low-grade antibody titers. But that does not mean that that particular patient has melioidosis. Sometimes in the PUO evaluation, PUO workup, you send melioid antibodies to the University of Colombo, and then you get it low titer, and then you can't label this patient as having melioidosis unless the patient develops or the patient's clinical presentation is compatible. And this is again an important thing I want to highlight, particularly for the medical trainees, that when we talk about pyrexia of unknown origin, your melioidosis come up in the list. But when a patient comes with a bad bronchopneumonia, who is collapsed at the time of admission to the ETU and was given fluids and started on vasopressors and sent to the HDU or ICU, the melioidosis is not one of your top differentials, right? You think about other causes. But mind you, most cases of melioidosis, 85%, result in acute infections from recent bacterial exposure. So your bad bronchopneumonia patient with multilobar consolidations who is septic, melioidosis is a possibility, because most of the time 85% melioid can present as an acute infection rather than a subacute or low-grade chronic infection in humans. So it usually presents with sepsis, with or without pneumonia, because the inhalation is common, and they can present with localized abscesses. Right, so this diagram summarizes like it can be anywhere, right? So pus anywhere in the body, particularly in atypical sites, melioidosis is a possibility. Starting from brain abscesses, mycotic aneurysms, prosthetic abscesses, and parotid abscesses, liver abscesses, splenic abscesses, you need to think about melioidosis. And I have not included here, but let me tell you one small story, a case that we have reported some time back. There was a farmer who was investigated for pyrexia of unknown origin. So we did most of the workup. We could not find anything other than elevated ESR and CRP, including a CT chest, abdomen, pelvis. But main complaint was he had fever and he was complaining of some headache, and he had LP also, which was negative. And then always he's pointing towards the right side of his head. And so when we felt his scalp, we felt a bit of a bogginess in the scalp. It was tenderness over the scalp. So then we got a scan, and then the radiologist reported there is some fluid collection beneath the gallia aponeurotica. That is this aponeurosis between the frontalis and the occipitalis. So then we got the surgeons to put a small nick and drain, and it was actually frank pus. And then to see, and this pus isolated, we were able to identify the organism exactly. It was a particular serotype of Burkholderia pseudomelia. So that was a localized melioidosis beneath the gallia aponeurotica without any other evidence of infection elsewhere in the body. So then on questioning, like 8 months back, this farmer had a fall while he was cultivating, and he hit his head in the paddy field on a rock, and he had a laceration. It was sutured and it healed. He completely forgot about it. So we assume that that was the point probably where the Burkholderia got inoculated into his scalp, and then it was growing slowly inside, making pus, causing fevers, but it was like clinically dormant for many, many months. Right? So atypical infections, atypical places where you get suppuration, you need to think about melioid infections. And then even with the best care, now we have a standard care, but the case fatality rate is fairly high. It's almost up to 10 to 50%, particularly in acute infections. And the other interesting thing is that 5 to 28%, like almost 1/3 of the patients, can experience recurrent infections. And then when we talk about melioidosis, we always talk about diabetes. We look for diabetes as one of the risk factors, right? So, because most of the patients, like more than 50% of patients with melioidosis, they have diabetes, right? So poorly controlled diabetes is a big risk factor which increases the risk of melioidosis by almost 12 folds. And there are many other risk factors to get melioidosis, right? So the occupational risk is you always have to consider exposure to soil or water. And then the male sex, the old age, excess alcohol, liver disease, chronic lung disease, chronic kidney disease, and thalassemia. So all these are reported well-known risk factors for melioidosis. But just because your patient does not have any of the risk factors, you can't tell this can't be melioidosis either, right? Because in patients with melioidosis, around 20% of adult patients, we can't find any recognized risk factors. There are no risk factors. And that is even more for pediatric patients. In children with melioidosis, for more than 80% of the pediatric patients, they were unable to find any risk factors that what we have discussed, right? So you need to think about melioidosis even in immunocompetent patients who have no other risk factors. Right, so how do we diagnose melioidosis? Well, the definitive diagnosis depends on the isolation and identification of Burkholderia pseudomelaria from clinical specimens. And it is not a difficult organism to grow, right? So most of your routine lab media using standard techniques will grow it. But the problem comes when it comes to identification of Burkholderia pseudomelaria, right? So, so you can see this typical, the metallic sheen of Burkholderia, and then this wrinkled paper appearance in different types of cultures, the black sheep blood agar and the McConkey agar, which contrasting from the E. coli, right? But this is the point I want to highlight. Now, recently also, I was telling this to my trainees that we had a patient transferred from, I think, Mayangane with a pyrexia of unknown origin. And then he was having high fevers and he was transferred. And then his initial blood culture was positive for Pseudomonas. And it was Pseudomonas culture. We have started on antibiotics. And when we turn to the ABST side, interestingly, this Pseudomonas is sensitive to coamoxiclam, right? But it is resistant to colistin and gentamicin. So this is a very interesting pattern that we see in melioidosis. So this is known as 3-disc diffusion antibiotic sensitivity testing, where generally the Burkholderia pseudomelaria is resistant to colistin and gentamicin, but it is sensitive to coamoxiclav outside the body, right? So if you see a patient blood culture report or a culture report which says a Pseudomonas species, and then in the other side you find that he is sensitive to coamoxiclav, resistant to genta, resistant to colistin, just give it a thought. This could be a melioidosis, or this could be Burkholderia pseudomelaria. Well, the other thing is regarding melioidosis serology. The most widely used one is an indirect hemagglutination test. We check for melioidosis antibodies. But the problem is the background seropositivity rates in some areas are fairly high, right? The farming areas, it can be fairly high. So just one antibody titer should not be used to diagnose melioidosis. And also there are cases where the cultures are isolated in Burkholderia, but the antibodies are negative throughout, because some patients with melioidosis never mount a good antibody response. Therefore, always you have to use your other senses, not only like fever with the positive melioidosis antibody titer, you take it as melioidosis, right? So the diagnosis of melioidosis should not rely entirely on the indirect hemagglutination test that we often do uh, to diagnose melioidosis. And the direct PCR assays, they're less sensitive, especially when it is performed on the blood. Right. So coming to the treatment of melioidosis, I think this you are very conversant with. I'm not going to talk in detail. We have an initial intensive therapy phase. A minimum of 2 weeks, can go up to 4 weeks or 8 weeks. And ceftazidime or meropenem is used. Particularly ill patients, septic patients, we use meropenem. And patients, particularly with superficial abscesses who are not very ill, ceftazidime can be an alternative. But you have to mind the dose. It is 2 gram intravenously 6 hourly. And if the patient has some neurological melioidosis like encephalomyelitis, brain abscesses, well, of course, the preferred drug is meropenem, and where we need to give the double dose, 2 grams 8 hourly, to adequate, sort of to get the adequate CSF penetration. And particularly some other in patients like neurological melioidosis in joint and bone infections like osteomyelitis and septic arthritis, and melioidosis in the genitourinary system like prostate abscesses, it is better to start the intensive phase with the trimethoprim sulfamethoxazole, because otherwise we continue the initial intensive phase and then go to eradication phase. But certainly in these instances, particularly affecting the soft tissues, the genitourinary system or the nervous system, it is best to combine the initial intensive phase of meropenem with the trimethoprim and sulfamethoxazole. And particularly in certain patients where they have complicated pneumonia, deep-seated abscesses, or neurological melioidosis or osteomyelitis, we might have to give a longer term of intravenous therapy, sometimes going up to 8 weeks. And the other important point I want to highlight here is this: the therapeutic response is slow, right? So just because you suspect melioidosis and waiting for the antibodies and the cultures, you give meropenem, and don't lose hope if the patient is still spiking fevers on day 5 or day 6. Because the median time to resolution of fever is up to 9 days, right? So your patient can be having melioidosis, clinically improving, but for a fever to settle by lysis, it might take more than a week, right? Okay, and then coming to the eradication therapy, the drug of choice is trimethoprim sulfamethoxazole, and sometimes patients do not tolerate this medication in long term, so the second line alternatives would be coamoxiclav and doxycycline. And certainly patients who have neurological melioidosis or bone melioidosis, osteomyelitis, you might have to go for a longer eradication therapy, more than 6 months. So so adjuvant therapy, the place of GCSF is controversial. Some use it with a rationale to counteract the functional neutrophil defects, particularly in diabetic patients. And then when it comes to the long-term sequelae, in melioid patients, the biggest problem is melioidosis-associated encephalomyelitis. So they can have a lot of disabling neurological deficits. And the other one is with the bone and soft tissue infections, particularly with the osteoarthritis, septic arthritis and osteomyelitis. There can be a limited range of motions, sinus tract formation, and joint deformities. And with regard to melioidosis vaccine, yes, no melioidosis vaccine is currently available, but there are a lot of trials underway to find the appropriate vaccine. Right, so that brings to the second part of my talk, melioidosis. So here I wanted to sort of highlight that melioidosis can present with acute infections you need to suspect, and how to make the diagnosis of melioidosis, and then to discuss about the basic principles in the management. Right, so I think that brings to the end of my today's talk, and I'm happy to answer any questions if you have.
Yeah, thank you very much, Chamara, for that very informative and excellent lecture, and also the fascinating cases you have discussed with us. I think we have several questions appearing in the Q&A. And I also invite the audience to mention your questions in the Q&A so we can take them for discussion. So I would like to share the QR code in the meantime for you to scan. Professor Dalugama, if you can stop sharing the screen, if you don't mind,
Yeah.
I can. Yeah. Thank you very much. So I hope you all can see this. So you can you can scan the QR code. And yeah, let me also, so I have also shared the link for the Google form in the Q&A. So you can just click the link as well. So going to the Q&A, the discussion of questions. So I will forward the questions to you, Chamara. So
Yeah.
first question is on, and you will also be able to see that how to get malaria prophylaxis in Sri Lanka. For how long stays are malaria prophylaxis given? Are rapid malaria tests available in Sri Lanka?
Yes, so to answer that question, yes, rapid malaria tests are available here. It is actually the kits are given to the wards as well. So in Peradeniya, like if we suspect a malaria patient, we can get the public health field officer to come and run the rapid test. I don't know the setting of the other hospitals, but it is available. And then how to get malaria prophylaxis in Sri Lanka? That is actually, I'm not sure whether it's available in private sector, but certainly even from private sector with a letter to the regional malaria officer or a letter to one of the teaching hospitals uh, nearby to arrange the malaria prophylaxis as a OPD referral can be done. So even those who are going to India, we just write the MOPD to arrange, facilitate it. So he will liaise with the either the regional malaria officer or in certain hospitals the PHFO to arrange the malaria prophylaxis.
Right. Thank you. So I think the next question is about this availability of the malaria prophylaxis in private sector. I think you have mentioned the answer. So moving to the next question on melioidosis. Any special reasons why the melioidosis prevalence slightly higher in eastern and northern parts of Sri Lanka? Any special reasons than agricultural landscapes?
All right. What I feel is like it's probably mostly contributed by the agricultural landscape. And also the other reason could be the increased awareness of the infection as well. Because when it is common, and then people tend to suspect it more, and then it can be sort of more diagnosed uh, at a higher rate than to the other areas of the country. But the most probable reason would be the agricultural landscape.
Okay. So another question, I think it's about ingestion of yams, sweet potatoes can cause melioidosis if contaminated in soil. What do you think about that?
Um, that's a good question, but I'm not very sure of. But certainly we don't eat it raw, so probably in the cooking process, uh, because it can get destroyed with the heat and all that. Uh, because the common source of getting this melioid organism is through the inhalation to the lungs, particularly during the farming season. This bacteria can sort of uh, get into aerosols and then can be inhaled or can be directly injected or inoculated into the body through the wounds, and then also from drinking water from the freshwater sources which can be contaminated. But of course ingestion of yams, I think, may not be a common source because we don't eat it raw, so we cook them properly. So during that process, I think although it survives in the extreme environment, this cooking, I mean, heated cooking can destroy the organism.
So thank you, Chamara. And there's another question on the cutoff serology titer. Is there a cutoff serology titer that would be confirmatory of melioidosis diagnosis?
Not a cutoff titer as such, but I mean, usually if it's an acute infection, you tend to get a higher titer. And one thing you can do is you can test the convalescent sera for a significant rise in the antibody titer, right? So there's no single value as such, but when you see very low titers and when it is not clinically compatible, we don't think of melioidosis. But certainly, if it is clinically compatible and the titer is low, what you can do is you anyway treat for the infection, and then you can repeat the samples maybe in 2 to 3 weeks time, and if you see a significant rise in the antibody titer, that confirms an acute infection of melioidosis, but no cutoff value as such.
And can we see splenomegaly during acute phase of infection?
Which infection? Probably referring to malaria,
Probably,
right?
I think we, yeah,
I mean,
probably, I
massive
think.
splenomegaly is a feature in common chronic malaria, but certainly any acute infection, not only malaria, but even and other infections. I mean, spleen is an immune organ, so a mild soft splenomegaly can be seen. But with chronic malaria, only you get a firm spleen, which can be fairly enlarged, which we hardly see these days.
The next question, yes, on cerebral malaria. Can we see meningism as a characteristic feature in cerebral malaria?
Um, which I'm not very sure of, because generally they get into a sort of unroused, I mean, a deep coma, and then this meningism is not a very classic feature that you see in cerebral malaria.
And yes, and the next question is about the fever patterns. So what type of fever patterns seen in your patients with malaria? So that was a question.
Right. So actually, for the first patient, actually we had clearly documented high fevers, but in like it was like patient was having daily high fever spikes going up to 100, 203 like. But for the second patient, actually, we was transferred from private sector and patient was taking regular paracetamol, so probably the fever was somewhat masked. We couldn't get a clear fever pattern as such. And soon after arriving to the hospital, he was diagnosed with the falciparum malaria, and he was started on IV artesunate. So, and then with time, fever settled. We didn't see actually the very classic, the textbook descriptions of fever in both patients.
Right. And another question is on drug-resistant malaria. Is there drug-resistant malaria species worldwide?
Right. So I think that question I'm not sure. Right. So because that's a standard treatment protocols depending on the different types of malaria. Right. So if it's a severe falciparum malaria, generally we either consider IV artesunate or IV quinine. And I have not read about such drug resistance compared to infections like tuberculosis. I'm not very sure sure about the answer.
So there's a question on malaria prophylaxis again. What about malaria prophylaxis for frequent travelers?
Right. So if you refer to that particular circular, and there are different, it's a very complicated table. That is why I didn't even copy paste it into my slides, because there is a place for such as well. So there are different drugs other than the chloroquine for Vivex and mefloquine for countries like Africa. There are other drugs like doxycycline, and there are different regimes that they have prescribed even for frequent travelers. There is, and in the last minute travelers, there are drugs that can be used.
I think so far we have managed to answer the questions asked. Yes. So are there any more questions from the audience? If not, I think Professor Dalugama, we can wind up this session. And yes, there's another. Let me see. This will be the last question, I guess. Maybe the one last question is, should we advocate malaria prophylaxis to all people traveling to India?
Well, that's a good question. I was also thinking about, because we do see even as we like we have been to several conferences in India and we didn't take malaria prophylaxis. But then when I met a community physician, because I asked this question, and actually the guideline advocates, yes, it is advocated.
Yeah. Okay, thank you very much. Thank you. So I think we can bring this to the closure. So I would like to extend my heartfelt gratitude to Professor Chamara Dalugama for delivering today's lecture and enlightening us, giving the insights into these tropical fevers that we should not miss in our clinical practice. And on behalf of the Sri Lanka College of Internal Medicine, let me extend my thanks to you again. And also, I think this for the audience, this lecture has been a very useful uh, uh, talk today. And also, I am confident this has been benefited a lot. So thank you again, Chamara. And I also thank all the participants who have gathered, and we can see a massive participation today, which really is heartening to see. So, so this brings to the end of today's forum, NextGen forum. So until we meet with another interesting lecture next month, I wish you all a very good night and all the best. Thank you very much.
Thank you, Sam.